patients, their family members, the psoriatic arthritis and psoriasis team, and you're going to get a chance to meet some of them, as I mentioned their name later on. And I also want to welcome our industry supporters. We'll find out who they are in a few minutes, right here. This event is sponsored by an unrestricted educational grant from Abbott Laboratories, Amgen Canada, and Merck Canada. I want to thank them for their support. And I want to introduce to you the members of the team. And you can see that this is a huge number of people. But I just want to introduce a few people that are here today that have come from overseas. Well, first of all, I want to introduce Dr. Vinod Chandran. Some of you recognize him as a clinical research fellow who's worked in the clinic. But as of October 1st, Vinod Chandran is now the Deputy Director of the Psoriatic Arthritis Program. And he's on staff, and he will be doing the Monday clinic in our center. So we're now 2 people running this show. I want to introduce Dr. Vern Farewell, who is a biostatistician located in Cambridge, England. I think Vern is up on the top somewhere. And his team, sitting next to him, is Brian Tom and Aidan O'Keefe. And they've traveled all the way from Cambridge to meet with us during the day today when we had our investigators meeting, and have stayed for this meeting this evening. Unfortunately, Richard Cook and Janice Houston were unable to make it today. They each hurt their backs on two separate occasions, I should say. And so they didn't make it. And Dr. Cheryl Rosen is here somewhere.
I'm here.
Some of you recognize Dr. Rosen as their dermatologist. Others should recognize her because she's involved in our psoriasis and psoriatic arthritis. Dr. Rahman was here earlier in the day, but had to go back to Newfoundland. And there are several clinical research fellows who are still training with us. Lily Eder, you're going to hear from tonight, and some of you know her as your doctor. Dr. Zahi Tuma, who is in the audience here. Dr. Hussein Asiri and Dr. Mohammed Agufaya. I don't know if they're here tonight. I mentioned Brian and Aidan. Fonda Pellet is our laboratory technologist, runs our HLA lab, and Remy Pollack, who is over there. He's a technician in our lab. Jeffrey Bernstein is a summer student with us. He's done a remarkable job this summer. And Sudha runs our psoriatic arthritis psoriasis program. And those of you who participate in that program will recognize her name. Arami is our biostatistician locally. She's on that side. And Adele is our research analyst. She's the one that enters all the data into the computer. And if she makes a mistake, we are in trouble. Maria runs our... she's the chef. Maria actually runs our international and national collaborative studies called IPART, the International Psoriasis and Arthritis Research Team that we're part of, and the SPARC, the Small Arthritis Research Consortium Canada. And Bernice, I don't think she's here, but she actually runs our database. She makes sure that Adele puts everything in, and Adele and the rest of us put everything in correctly. Daniel is a jack of all trades. He helps us with everything. And Anne McKinnon, right there, she actually runs the show. Jackie runs our clinic, and many of you recognize her. And I don't think Jackie Pereira is here. She helps Jackie. And then we have 2 nurses that work in our clinical trials unit. In addition to the support that we got tonight specifically for the educational component of this symposium, the Psoriatic Arthritis Research Program gets its support from a number of sources. Most importantly is the Krembil Foundation, without whom we would not be anywhere with our program today. The Canadian Institutes of Health Research and the Arthritis Society have both contributed to our grant support for individual projects. The Canadian Arthritis Network has sponsored some of our fellows and some of our medical students, summer students. The Arthritis and Autoimmunity Research Center has supported some of our fellows, and the Toronto Western Research Foundation has provided a venue for all of these support to go through. I want to alert you to a couple of things. First of all, the Psoriasis Society of Canada is running the National Psoriasis Walk that our own SUDA is taking part of. And so you have some information of how to contact in case you want to participate in this walk. It is going to be on Sunday, October 24th. And lastly, I want to highlight the fact that we've given you an evaluation forms, and we would appreciate if you remember to complete them and return them so that we can make better programs for you in the future. So without further ado, what I'd like to do is start with the program. And our first speaker is Dr. Rosen, who's going to talk to us about psoriasis and its impact. And if I remember what to do here, we will get Dr. Rosen's presentation up right now.
Well, good evening, everybody. Thank you for joining us here. I'm going to be talking about psoriasis and its impact, the quality of life in people with psoriasis and psoriatic arthritis. And as you know, psoriasis is a disease that involves the skin and the nails. It affects 3% of the population. It is not contagious, and there is a familial tendency. And there's just a sample of plaque, the erythema, which means redness, the thickness, the scaling, a very typical spot of psoriasis. And there is the typical nail changes, with the nail being raised off the nail bed, with the pitting on the surface. So as you know, psoriasis may be uncomfortable, it may be itchy, it may interfere with a person's ability to work, with their ability to walk. It may cause embarrassment due to the appearance of the lesions, and unfortunately, sometimes it may lead to low self-esteem. We know that psoriasis is not just a skin disease. About 30% of patients develop arthritis. There's an increased risk of heart disease, and there's recent evidence to show that there's an increased risk of metabolic syndrome, which means there's an increased risk of diabetes, obesity, high blood pressure, elevated cholesterol, and triglycerides. And then just to talk about psoriatic arthritis, it's an inflammatory arthritis with pain, and there can be decreased mobility. Some people who have psoriatic arthritis have absolutely no complaints whatsoever. They don't even know they have arthritis, but other people are greatly affected. So when we talk about quality of life, we're really talking about the physical, social, and psychological effects of a particular condition on someone's life. What kind of stress does it bring to that person? How does it disrupt their daily routines? And so our question was, does having psoriatic arthritis further decrease the quality of life in a person who has psoriasis? I would have thought that automatically my answer would be yes, indeed it must. And in fact, several studies have reported a decrease in quality of life in people who have psoriatic arthritis along with psoriasis. However, one study did not find out at all. They found that the quality of life was the same, whether you had arthritis or not. And so the question is, how do you best measure quality of life? You can ask people how they're feeling, how it interferes with all the activities that they're doing. And indeed, multiple questionnaires have been developed to assess quality of life, both in terms of pain, fatigue, how it affects your job, how it affects your life at home, how does it make you itchy, and it also, some of them address mood, talking about depression, anxiety, pain, and fatigue. And so our study that we did looks at people with psoriasis alone and people with psoriasis and psoriatic arthritis. And these people kindly filled in 5 different questionnaires. 4 of them showed that people with psoriatic arthritis have a decreased quality of life compared to people with psoriasis alone. 1 of the questionnaires asked questions about the effects of skin on quality of life. So it was really particular to the psoriasis aspect. And people with psoriasis, not surprisingly, had more difficulty with skin-specific issues. So people with psoriatic arthritis have a decreased quality of life compared to those with psoriasis alone, as assessed by 4 of the questionnaires that we used. And people with psoriasis alone noted a greater impact of their skin disease on their quality of life. And what you should know is that these people generally had more significant psoriasis, which is what this PsA score means, than people who had psoriasis and psoriatic arthritis. So it stands to reason that the psoriasis may have impacted them more. I don't need to show that. There we go. The end.
So we do have a couple of minutes for questions. If anybody has a specific question for Dr. Rosen.
Yes?
My question is, why would it increase heart disease?
That's a very good question, and in fact, people are actively researching that. But it seems that if you have inflammation in your skin, it increases the inflammation in your blood vessels. So your coronary arteries, the vessels that bring the blood to your heart, can be affected by that inflammation. And that can lead to increase in heart disease. And also there seems to be an increased risk of obesity and diabetes. So all of those are factors for heart disease.
And did the other, I didn't manage to write down all the other things that supposedly increased, but were they also increased by inflammation? Like you had diabetes and I'm not sure what else.
Hypertension, increased cholesterol, blood pressure.
Yeah.
So we're not entirely certain how they're all related, but a lot of it is thought to be due to the increased inflammation.
We'll be able to tell you next year. Because we actually have a grant to do just that, to look at some of the reasons for that.
Thank you. So the question is that because of psoriasis or psoriatic arthritis?
We'll answer that next year too.
Sweet.
But people who don't have psoriatic arthritis and have psoriasis alone are at increased risk for these things. So it is psoriasis alone as well. Yes?
I have a question that's related to psoriasis alone. So the question is, in order to, and that was not mentioned in that presentation, but to remotely improve the quality of life, what foods should people with psoriasis avoid in order not to exacerbate these psoriasis? And are there any international studies, or is there any research conducted with that respect?
Well, as far as we know, there are no particular foods to avoid and no particular foods to eat in increased amounts to affect psoriasis. As far as we know, food does not make a difference.
Is there any research being conducted?
There is research that has been conducted because people look at environmental factors. They look at what the diet is. They look at what, whether people smoke. They look at physical activity. So yes.
Okay, one last question.
How long has it been since psoriatic arthritis was identified as an issue? Because I think as a kid I had psoriasis, my mother had it, and yet when I was diagnosed with having psoriatic arthritis, and I tell people today, most people still looking at a blank face like, what was that?
It was first described by a guy by the name of Ali Berti in 1818.
Wow.
It's been recognized as an entity by itself, separate from rheumatoid arthritis, since the mid-40s. So it's been known for a while, in the 1940s. All right.
Are you still treating it topically as well as ingested, let's say, medicine?
Absolutely,
For psoriasis?
yes. Topical
What are you
treatment,
using for topical?
well, it depends on the part of the body, it depends on what the psoriasis looks like, but there's a variety. We use topicals, we use steroid creams, we use vitamin D analogs, we use tar still.
Are you still using ultraviolet light?
Absolutely, we use, we've moved away from broadband ultraviolet B phototherapy to, now we use narrowband ultraviolet B. It's more effective than broadband. We don't use PUVA as much anymore as we used to because narrowband is more effective than broadband.
How about tar?
Tar with the phototherapy, yeah, we can still do that. Not usually the black stuff anymore.
Okay, so depending on the time, we may actually ask you to hold questions until the panel discussion at the end. The next speaker is Dr. Lee Eder, who is a research fellow in our unit, who is actually working on her PhD.
Hi. I'm going to present to you today the results of two studies that I've been involved in and we recently finished in the psoriatic arthritis and psoriasis study. So I'll first talk about the background of these studies. Dealt with environmental risk factors for psoriatic arthritis among patients with psoriasis. So I'll talk first about the background and then present to you the results of the first study that assessed environmental risk factors for psoriatic arthritis among patients with psoriasis. And then the second study assessed the incidence or the rate of psoriatic arthritis among patients with psoriasis. So psoriasis is a disease that is mediated by the immune system and affects about 2% of the general population. It usually presents with red flags with scale, but there can be other types of psoriasis. And psoriasis is associated with other diseases and can lead to decrease in quality of life. And psoriatic arthritis is an inflammatory arthritis that is associated with psoriasis and affects about 30% of the patients with psoriasis. And this disease can lead to a severe joint damage and disability. We can consider psoriatic arthritis as a disease within a disease, as most people first develop psoriasis and only later develop psoriatic arthritis. So the main goal of our study was to identify patients with psoriasis that are at increased risk of developing psoriatic arthritis. Psoriatic arthritis is considered a multifactorial disease, like many other chronic diseases like hypertension or diabetes, where environmental risk factors are important in the mechanism of the disease, as well as genetic risk factors. And we also think that there are different genes that are associated with development of the skin disease that are different from the genes that are associated with the joint disease. And we also think that there may be an interaction between the genetic and environmental risk factors. So, for instance, people that have the genes that are associated with the joint disease, maybe if they are exposed to environmental risk factors, only then they develop psoriatic arthritis. But that's a model that we have to prove. So there's been only 2 studies in the literature that assessed environmental risk factors for psoriatic arthritis among patients with psoriasis. And these studies suggested that physical trauma such as injury, rubella vaccination, moving house, steroid use, and pregnancy, which was a protective factor, were associated with the development of psoriatic arthritis among patients with psoriasis. However, these studies were very small, and therefore we have to take in caution these results. Smoking is a known risk factor for psoriasis, and it's also associated with more severe psoriasis and with poor response to therapy. In psoriatic arthritis, there are only limited data about the association between smoking and psoriatic arthritis. There was one study that suggested that smoking may actually increase the interval of time from development of psoriasis to psoriatic arthritis, and by that may be sort of a protective factor. And other studies could not find an association. So the main goal of our first study was to identify environmental risk factors for psoriatic arthritis among the patients with psoriasis. So this was the design of the study is called case control study, and we compared two groups of patients. The first group was patients with psoriatic arthritis, with early onset psoriatic arthritis of less than 7 years, because we wanted them to remember what happened before the disease started. And the group of comparison was patients with psoriasis only that do not have arthritis. And we assessed a wide range of potential environmental factors, like physical trauma, including injuries and fractures, infections, vaccinations, emotional stress, such as divorce or death in the family, female hormonal exposures, such as pregnancies or hormone replacement therapy, occupational exposures. Mainly we were focused on mechanical stress, like prolonged standing or moving heavy weights, and smoking and alcohol consumption. We asked the participants to report about events of exposure to these factors over the past 10 years, and then we compared the proportions of patients that had positive exposure to each of these factors that occurred before their disease started. And in the statistical analysis, we took into consideration the differences in age and sex between the two groups. So these are the results. We found that there was increase in infections that required antibiotics, infections that required hospitalizations, lifting heavy weights as part of occupational tasks, and injuries, which was borderline associated with increased risk of developing psoriatic arthritis. Smoking, on the other hand, was decreased in the group of psoriatic arthritis patients and was sort of a protective factor, but I wouldn't suggest any psoriasis patient to start smoking. There was no association with alcohol consumption, vaccination, stressful life events, and female hormonal exposure. So the conclusion from this study was that lifting heavy loads as part of occupational exposure, infections that required antibiotics, and possibly injuries were associated with psoriatic arthritis among patients with psoriasis, and smoking and past smoking were decreased among psoriatic arthritis patients. The second study was aimed to determine the incidence or the rate of development of psoriatic arthritis among patients with psoriasis. So for this study, we've used the Toronto Psoriasis Cohort, which was established by our group in 2006, and includes patients with psoriasis that was confirmed by a dermatologist. And these participants are evaluated by a rheumatologist before they enter into the study to exclude the presence of arthritis, because we are interested only in patients that did not develop yet arthritis. And then we follow them once a year and we assess them to see if they've developed psoriatic arthritis. And if they do, then we transfer them to the psoriatic arthritis clinic. So we analyzed the information about patients that were recruited to the study from January 2006 until December 2008, and had at least 1 year of follow-up until December 2009. We had 313 patients. As you can see, most of them are recruited from dermatology clinics and phototherapy center, and therefore they represent a more moderate to severe range of psoriasis patients. Some of them are recruited from local advertisement and general rheumatology clinics. Overall, 10 participants have developed psoriatic arthritis over the 4 years of follow-up. And the annual incidence rate was 1.87 psoriatic arthritis cases per 100 psoriasis patients. So in other words, it means that for every 100 psoriasis patients, 1.87% of them develop psoriatic arthritis every year. And the statistical analysis suggested that the risk is constant over time. So the conclusions from these study were that the incidence rate of psoriatic arthritis in patients with psoriasis is higher than previously reported. So the take-home messages from my talk is basically that the rate of psoriatic arthritis among psoriasis patients is probably higher than we thought before, that the risk remains constant over time, and that there are several risk factors that are associated with the development of psoriatic arthritis among patients with psoriasis. Our future plans are to continue to recruit the patients for the psoriasis study and to continue to follow the patient in the psoriasis study. And we intend to analyze to see whether there is an interaction between genetic risk factors and environmental risk factors that are important in the development of psoriatic arthritis among the patients with psoriasis. So I would like to thank the psoriatic arthritis research team, all the members that participated and helped in this study, the CIHR, the Krembil Foundation, CAN, for helping to support our studies, and all of you for participating in our studies.
So we do have time to take a couple of questions.
I noticed that in the first presentation, they mentioned 3% of the population. In this one, it was 2%. That's a 50% difference. How could that take place?
Different studies in different populations show that the prevalence of psoriasis ranges between 2 to 3%. So it probably depends on which population you assess.
When you say populations, are you talking about other countries, or
Yes.
with the 3% that was mentioned, is that with regard to Canada then?
We actually don't have good incidence or prevalence numbers for Canada. We think that in North America, based on a study that was done by the National Psoriasis Foundation in the US, that the prevalence is 2.5%. In certain parts of Europe, if you go up to Northern Europe, the Scandinavian countries, it actually goes up higher. And in fact, even if you go to Newfoundland, the incidence of psoriasis is higher than probably in the rest of Canada. So usually we use the numbers 2 to 3%, and you can see that one person picked the 2 and the other person picked the 3. That's the average across the world.
Is there any geographical area that is low?
The people in South America tell me that the prevalence of psoriasis in South America is low, but when I went to visit them, what did they show me? Psoriatic arthritis. So, I don't know. That's what they tell us, that it's low in South America.
Are there any studies to find out why smoking might increase
This is the first study that has shown these results. The 2 other studies that assessed environmental risk factors were very small, so maybe they were not able to show the difference because they didn't have enough people in the study. We actually checked the smoking status in all of our groups of psoriasis and psoriatic arthritis patients, and we found the same results. So I don't have a good explanation because this is the first time that it's been shown.
You're not recommending though that
No, I definitely don't recommend to start smoking because smoking is associated with many other diseases than this.
Is it more of a male-female thing? Like, what in your studies? Are females more inclined to have it, or there's no gender basis in this at all?
In the statistical analysis we adjusted, we took into consideration the differences in sex or differences in gender, and it made no difference in terms of the factors that I have shown to be important.
You should know, though, that psoriasis and psoriatic arthritis are equal opportunists. There's a slight male predominance, but it's really quite slight. Just a little over 1.1 or 1.2.
Regarding infections that may contribute to the development of psoriatic arthritis, and which also require antibiotics. Is there any specific infection that you found to be more common than other infection? Which infection would that be?
Diarrhea was more common among the infections, although the statistical difference was not significant. Other specific infections were not, including viral infections.
And which infection would that be?
So skin infections and upper respiratory infections, so we couldn't find any specific infection what that was.
Since psoriasis is treated with ultraviolet and other methods, let's say salt water, don't you find that psoriasis is more predominant in the northern hemisphere, in the colder climates? We were mentioning Sweden and Norway and so forth. Just talking on my own, that when I had severe psoriasis, the best way to get rid of it was to go down to the Bahamas, soak in the salt water and get a lot of sun. So wouldn't there be a decrease in this, let's say, southern United States as the northern United States?
You would think that might be the case, but psoriasis is actually quite prevalent in Italy, which is actually in the south of Europe, in Israel, in India, which is quite warm. So there seems to be more than just the environmental or geographic situation. There seems to be more in terms of genetics, which we're going to hear about in a minute.
In your studies, have you noticed any kind of correlation between something like gout and psoriatic arthritis? Is there any relationship there at all?
We know that gout is more prevalent among people with psoriasis. We think it's associated with the metabolic syndrome that is more common in people with psoriasis. But we don't think that gout leads to psoriasis.
So it's not an indicator.
No.
And why do you, like I've had psoriasis for many years and I've now developed, is it when you get older you develop the arthritis or some, like is it older or can younger people actually get the arthritis?
Oh, I mean, there are children who develop psoriatic arthritis. In fact, in children, it's a little bit more difficult to diagnose because they often present with the arthritis before the psoriasis appears, and it makes it very difficult to diagnose them. But you can get, the mean age of onset of psoriatic arthritis is usually in the mid-30s. The mean age of onset of psoriasis is in the latter part of the 20s. That's on the average. But we have psoriasis and psoriatic arthritis beginning in childhood, and we have people that present in their 70s and 80s for the first time with psoriasis and psoriatic
My
arthritis.
sibling, he doesn't have it, I have it. Does that mean he's going to get it eventually?
Well, tell him not to. There's
I understand that there are two different genes. One gene for causing, if I can use the word, psoriasis, and the other one causing psoriatic arthritis. Is that correct?
The theory is that there may be genes for psoriasis and different genes for psoriatic arthritis, and this just gives us a prelude to the next lecture by Dr. Vinod Chandran about the genetic factors in psoriasis and psoriatic arthritis. So Vinod,
Thank
this
you.
is his first lecture as staff.
I go to the pager, I'm on call, so excuse me if I have to leave in the middle of the talk. So, okay. So what I'll do now in the next 10 minutes or so is give a brief overview of genetic factors and what we call biomarkers in psoriasis and psoriatic arthritis. And I'd like to make some disclosures. I am supported now by salary support from the Canadian Institutes of Health Research. I've also received honoraria from the companies listed here, Bayer, Abbott, Schering-Plough, and BMS, during my training. And these companies do make drugs for psoriasis, psoriatic arthritis. So the outline of my talk would be a little bit of a background on genes, DNA, and disease, and then I'll go to some specifics of genetics of psoriasis and psoriatic arthritis, and talk briefly on the biomarkers. So let's start with the genes, DNA, and disease. So the question that many of you, at least I have, is that why should we study genetics of disease? It's relatively expensive to do so. So we do genetic studies to understand why someone gets a disease and why different people with the same disease have different outcomes. You all have psoriasis, I guess, and some of you have psoriatic arthritis, some have very mild psoriasis, some have very severe psoriasis. So the question is, do genetic factors play a role in this, the expression of the disease? And the second reason why we do these studies is to discover new molecules that cause disease. So if you identify a gene and then understand how the gene causes disease, then you can develop a new drug that can block that protein and help treat the disease. So that's one of the main reasons why we do genetic studies. And it's also, and the one important reason also is to predict. Although I'm not sure if it's going to be that easy in complex diseases like psoriasis. So the question is, if you have a particular gene or a gene variant, are you going to get the disease or not? And in family studies, that's the main question. Is my sibling going to get it? Is my child going to get it? So that's an important question. The other prediction that we're interested in is that can we predict beforehand if a drug is going to work or not, and if they're going to have any side effects. So these are the reasons why we do genetic studies in any disease. And what is a gene might be a question. This is a cell in the body, and there's a nucleus with the DNA inside, and the DNA is wound in a tight coil in chromosomes, and if you unwind the coil, you get 4 letters, C, A, G, and T, and that's what is genotyping. So you take your blood, from your blood, take the cells, the DNA, and then we try to, using various techniques, get those 4 letters out, and then compare between people who have the disease and don't have the disease to see if there's a difference. So that's what a genetic analysis is all about. And then in human beings, there are 23 pairs of chromosomes. So this is all depicted here. You'll see this kind of slide 2 more times. And what I'm showing here are the chromosomes. There are 23 pairs of chromosomes. So I'm just showing one pair, one of each pair. So there are 2 of these, and 2 of the next, and 2 of this. So it's chromosome 1, 2, 3, and generally the size goes smaller as we go ahead. And then these are the 22 chromosomes, and there's the X chromosome and the Y. So females have X and Y, sorry, X and 2 X's, and men have X and Y. So that's, and you're just getting these material out of you and then looking for the 4 letters to see if there's a difference. And then when you talk about diseases, a genetic component of a disease, like Lee here just talked to you about, there's a genetic component and there's an environmental component. And it's every disease has a genetic and environmental component. Some diseases have a strong genetic component, very little, a strong genetic component with environmental issues playing a small role. Some have more of the environment being more important, and some diseases have mostly environmental factors, the genes playing less of a role. And examples of this would be, the first group would be diseases like Down syndrome or cystic fibrosis, where genes make most of the contribution, although there are some differences due to environmental factors. And diseases like AIDS, caused by a virus, mostly it's the virus that causes the disease, but how you behave after you get the virus depends on your genetic factors. And diseases like psoriasis and psoriatic arthritis have a strong genetic component and also an environmental component. That's why some people with so-called genes don't actually get the disease, because they don't have the right or wrong environmental factor. So it's easy to say all this, but how do you actually do a program to identify genes for a particular disease? What we do is, most importantly, define what the disease is. So recently we had a lot of discussions on what is psoriasis. So our definition is, the disease is diagnosed by a dermatologist, but that's not a very good definition from a scientific point of view. For psoriatic arthritis, we say, okay, you have psoriasis, diagnosed by a dermatologist, and you have inflammatory arthritis, and there are some criteria called CASPER criteria that we use to define the disease. So first important thing is you know what you're looking for. The disease that you're looking for. You can't just presume that somebody has a particular disease. And the next thing to understand if the disease has a strong genetic component is to study the disease in families. So if the genetic factors are important, the disease would tend to run in families compared to people to somebody else who does not without psoriasis. So you see if immediate family members of patients with psoriasis have more psoriasis compared to somebody else who does not have psoriasis. So that's when you do that and you get a number which is more than 1, then you know that there is a familial or a genetic component. And then what you do, once you know that there are genes involved, you need to collect a large number of patients. With technology that is available, you can look for genes with small effect if you have enough number of patients. So if you look at diseases like diabetes, heart disease, Crohn's disease, they have tens and thousands of patients who have been genotyped. Psoriasis, not that many. And we're getting there, but compared to the other diseases, we are not there yet. So you collect all these patients and then test and identify the DNA code and then compare that to people without the disease, and that's where the statisticians come in. They compare these huge databases of the sequences of individuals with the DNA and see at a particular location is it different, and is it different identifying patients with the disease. And once you identify a gene by genotyping and statistical analysis, we then have to go to the lab to see how is the protein different and how does that altered protein cause the disease. So many of the genes that have been discovered, we have not actually done this yet. And we presume, based on knowledge of biology, that this is what it's supposed to do. And we presume that's what's going wrong in the disease. And then coming specifically to the genetics of psoriasis and psoriatic arthritis, the important questions when we look at genetics of this disease is to identify markers that are common to both diseases, and then to look for markers that are specific to the skin disease, and those specific to joint disease. And then, importantly for us, to identify markers that predict the development of arthritis in patients with psoriasis. And also important would be to identify markers of severity, because if you have very mild arthritis or a couple of spots of psoriasis, it doesn't really matter, maybe not, but if you have really bad psoriasis and if you can identify that, people destined to have that kind of disease, it's important. So these are the specific questions we have in mind when we do a genetic study. And so we've done family studies to see if genes are important. And in psoriasis, studies done elsewhere have shown that immediate relatives of patients with psoriasis, that when I'm saying immediate relatives, I mean the first degree relatives, parents, children, siblings, they have 4 to 10 times higher risk of having psoriasis compared to somebody else who does not have a family history. And if you look at psoriatic arthritis, the risk is 30 times. And the number is higher because compared to psoriasis, psoriatic arthritis is it's a rarer disease, right? So because only 30% of people with psoriasis have the disease. So these numbers indicate that genes are important, and so it's worthwhile going ahead looking for genes. Otherwise, why spend all that money to do something when there's nothing there? And then I'm just briefly reviewing many number of markers that have been discovered. This is the slide which describes the markers identified for psoriasis. So these are the chromosomes. You recognize the chromosomes, and the red spots here that I'm showing are the genes that have been shown to be important in at least 2 studies. So 2 studies being 2 independent studies, and so there is some validity to that, because when you do a study, there's a chance that you're just finding something which is not really there. And more recently, they've done bigger studies with thousands of patients and what we call genome-wide studies, genome-wide association studies or GWAS. And these studies have shown some genes that we knew were very important, like genes in the chromosome 6 PU region, which is an important region for autoimmune disease. So that is a gene there. And it's HLA-C6 and maybe some other genes lying close to that. And there's a gene called IL-12B40, which is important, and it's on 5q. And then there's IL-23A. These, names are not important. I'll come to you why it is important shortly, but these are the genes that have been shown to be important in a genome-wide association study. So these genes are definitely associated with the disease. The other genes may or may not be, and as we get more patients and do more analysis, we might be able to confirm or refute the other genes, and maybe identify other genes of importance. And there's one there too. And this slide looks at genes for psoriatic arthritis. The green ones are the genes for psoriatic arthritis. The red are for psoriasis, which I just left it there just as reference. And the number of studies looking at genes for psoriatic arthritis have been few. And so you can see that, not many genes have been confirmed to be associated with the disease. But what we know is that the autoimmune region is important. IL-23R is important. IL-1 is important. And we have done a lot of work on cure genes, and all these genes are important for the disease. And although there's not been a formal comparison between patients with just psoriasis and with psoriatic arthritis, but with the data available, we've done comparisons to show that HLA-C6 and IL-23R and these genes are probably associated with the skin component of the disease, and these genes here, B27, IL-12B, 2 copies of MK00801, IL-13, 221, they are more associated with the arthritic component of the disease. And we need to work much more to identify genes that are really associated with the skin and joint disease. And the question is, okay, we have some knowledge, and has that knowledge helped in any way? And from the psoriasis genome-wide association studies, what we have understood now is that 2 immune pathways are important in the disease, Th17 pathway and the NF-kappa B pathway. The names are not important, but what is important is that there were already drugs in the market which were shown to be effective for psoriasis, and these drugs actually block these pathways. So ustekinumab, also known as Stelara, blocks the Th17 pathway. The anti-TNF agents work downstream of the NF-kappa B pathway. So we know that these drugs work, and now we have studies to show that these pathways are important in the disease, and so it makes sense. It's an important confirmation. And the hope is that with larger, better defined studies, you can identify more pathways and then test molecules that will inhibit these pathways and develop newer drugs, because not all patients respond to anti-TNF agents or ustekinumab. So in future, what we need to do is to do large genetic studies to scan the entire DNA using maybe million or more than that markers, or even sequence the genome to identify genes for psoriasis and psoriatic arthritis, identify genes and environmental factors, because as I said, environmental factors are also very important, and also identify markers that will predict response to treatment with drugs like methotrexate, which is effective in a lot of patients, and also the newer biologic agents. So that's where we need to go with the genetics. And then, of course, I try to identify genetics of disease severity. And the first thing that we need to do is to define what severity is, because that's not very clear sometimes. And the next small part of the presentation will be on biomarkers. It's a relatively new concept, and so I'll give a brief description of what it is. So what I've talked until now is about DNA. And we know that the DNA is a template that is present in all cells of our body, but how it works and how DNA affects the body and causes disease is that DNA is transcribed to form RNA, and then RNA forms proteins. And the proteins are present in the organ or the tissue or cell, and abnormal proteins cause abnormal tissue function. That leads to disease, and disease manifests as symptoms and signs. And when you do investigations, you get abnormal blood tests or abnormal X-rays or MRI. So these are the outcome measures that you're looking for, because the doctor or the clinician sees this, and then you're trying to figure out, what is wrong here. And any of these tissues, any of these markers that are abnormal can be potentially used as a marker for the disease, or a marker of severity of disease, or response to therapy. And I've discussed biomarkers in the context of DNA, but we can do similar analysis of the RNA, and we have done studies on that, and also look at proteins or even cellular tissue. But what most people are interested in is in the proteins, and the idea is that if the protein is abnormal and is present in the blood, and if we can definitely identify that protein, then by testing that protein in the blood, by a simple test, you can detect the disease, or at least increase the likelihood that you have the disease or not. So biomarkers, especially protein biomarkers in the blood, are important in a more practical clinical setup. And the problem is that with psoriatic arthritis, there are no biomarkers currently available. And many of you would have experienced that you think there's a problem, you go to the doctor, he orders a blood test and says, well, the tests are normal, you don't have a problem, there's no arthritis. So a lot of patients say that, well, I've had my arthritis tests and they're all fine. But when you look at them, you do X-rays and MRI, you see a lot of problems. The problem here is not that there's no problem, but that there are no biomarkers. The blood tests that are routinely done are all normal. And so we see that more than 50% of patients with active disease have normal inflammation markers in the blood, and which is a big problem in, especially in primary care, because all patients with psoriasis cannot be seen by a rheumatologist. And so if we can have a good blood test to identify the disease, it'll help the dermatologist, it'll help the family physician to identify the disease. So identifying biomarkers, especially soluble or serum biomarkers, are important. And so we first did a pilot study to see if biomarkers are important or not, and also to test if by doing a few markers can we differentiate people with just skin disease with patients who have skin and joint disease. So we used a convenient sample of 78 patients, 78 subjects, 26 who were normal controls, and 52 with what we call psoriatic disease. So they had psoriasis with or without, without arthritis. And 26 of them had just psoriasis, and 26 had psoriasis and psoriatic arthritis. And this is how we defined what they had. And then we did a few blood tests, which are here. These are markers based on literature. We looked at what is abnormal in arthritis and skin disease and said, okay, these markers may be of importance. So we looked at markers of inflammation, tissue damage, bone damage, cartilage damage, and repair, and some immune markers. So we got your blood and tested this in a small number of patients, and to see if any of these markers differentiate between psoriasis and psoriatic arthritis. And what we saw was that highly sensitive CRP, which is a marker of inflammation, osteoprotectin, MSP3, and cartilage markers, a ratio of two of them, have very strong discriminative ability. And so we think that by identifying protein molecules in the blood would greatly help in the diagnosis of arthritis in patients with psoriasis. And so we need to, this was a pilot study just to generate data so that we can apply to funding agencies to get more money to do this. So this is what we're intending to do. And so with the biomarkers, what we plan to do now is to, again, to have a two-pronged approach. We look at the literature and identify molecules that we think are important, but also maybe there are molecules that's not available in the literature. So then what we're going to do to identify novel molecules is to take, in a small number of patients, just 10 skin biopsies from the psoriatic lesion and from the normal skin, and also get synovial fluid So a lot of you come with swollen knees, swollen ankles, and we take the fluid and we do store it, but some places it's just discarded. But that's an important tissue that is easily available and is obtainable in a clinically indicated procedure and without any risk. So if we can have enough of those fluids, then we can compare and we can examine the fluid to identify proteins and then look in the blood to see if these proteins are there, because looking for proteins directly in the blood is a lot of garbage. You just can't get anything because molecules like albumin, which is present in huge quantities, mask everything else. So by doing this, identifying these proteins in the skin and in the synovial fluid, and then after that looking in the skin, in the blood, we may be able to identify biomarkers of importance. And then we'll test it in patients who have psoriasis and psoriatic arthritis and see if these markers help us identify the disease. So, and also identify if some of them, if it predicts developmental joint damage. So this is a future plan that we intend to do. We've applied for funds for this. And finally, just to summarize, just go through what I've said, just to give you some take-home messages. Important genetic factors are important in psoriasis and psoriatic arthritis, no doubt about that. The genes for psoriasis include HLA-C6, IL-12B, IL-23R, TNF-AID3, and TNF1 and IL-4. And for psoriatic arthritis, HLA-B27, IL-12B, IL-13, IL-2, IL-21. They're all important. We think that biomarkers will be clinically useful as a practical tool for identifying psoriatic arthritis in patients with psoriasis, because there's a lot of undiagnosed psoriatic arthritis in patients with psoriasis. The markers that we have tested that have turned out to be important are HSCRP, MMP3, OPG, and cartilage markers. And we're continuing to do these studies to identify both genetic markers and protein biomarkers for both psoriasis and psoriatic arthritis. And that's all. The Vector of Knowledge, the Grebel Foundation, CAN, ARC Foundation, CIHR, and UHN for Henry Pieri Scholarship. Thank you.
And we'll move on to more potent medications. Again, I need to acknowledge that I'm a consultant to a number of companies and get grant support from a number of companies. I usually say that I'll consult to anybody who will listen, and I'll take money from whoever will give. And so what we're going to talk about quickly about the clinical entity, we got some glimpse into it, and we'll just get a few more glimpses, then talk about the goals of treatment, and talk about the therapeutic advances. So psoriatic arthritis is an inflammatory arthritis. It means it presents with pain, swelling, redness, limitation of movement, and it can affect the peripheral joints, as we see here, as well as the back, as we'll see in a minute. It is usually negative for rheumatoid factor, and as Vinod was saying, the doctor will tell you that you don't have a positive test for arthritis, because in psoriatic arthritis, you don't have a positive test for arthritis. And there are a number of associated features, such as inflammation in the back, inflammation at the insertion of tendons into bone. It's called enthesitis, inflammation of the whole digit, that's called dactylitis, inflammation in the eye, it's called iritis. You can get inflammation in the mouth that presents with mucous membrane ulcers, like little canker sores. There can be sores also in the urethra, which is where the urine comes out. And there are a number of other features that are associated with a group of diseases that we call seronegative spondyloarthritis. Now, when we look at patients with, when we look at the disease psoriatic arthritis, the end organ is two. There are two end organs. One is the joint, and one is the skin. And in the joint, we have inflammation, which is synovitis, enthesitis, and we can get bone resorption and ankylosis. And what you can see here are the hands of a woman with psoriatic arthritis. And you can see that there's a shortening of this digit over here, and maybe in this digit over here. And when you look at the x-rays, there is a significant amount of joint destruction. That's what we want to avoid. And that joint destruction is a result of inflammation that this person has had in previous years. So we want to turn off the inflammation to prevent this from happening. This is what the dactylitis looks like, inflammation of the whole digit. You can see a little bit of redness over the joints because the joints are inflamed, but in addition, the tendons are inflamed and even the soft tissue between the tendons and the bones. And here you can see inflammation in the insertion of the Achilles tendon into the bone, the calcaneus. And it's red and it's swollen and it can be very painful. And we've seen the pictures of psoriasis before and the nail lesions, which are the areas of the skin that are involved. So the word inflammation is crucial here in the skin and in the joints. As we heard earlier, it's inflammation that leads to some of the other problems that we have with the metabolic syndrome and the heart disease and so on. Now, in the outcome in psoriatic arthritis that we want to avoid is this kind of thing. This is total resorption of bone. You can see again that these digits are very short and there is a total disruption here of the joints. We want to avoid that. And we certainly want to avoid this. You can see here, this is what the thumb looks like. And when you pull on it, you can actually make it go to the 4 centimeters it was supposed to be in the beginning. But this happened because there's absolutely no bone left in this thumb. We do not want that to happen. Likewise, you can see here that there is involvement of the back, and you can see why these are supposed to be very plain, and these are all just like here. And they're joined by bone. This is called syndesmophytes, and that's what we see in psoriatic spondylitis. We can see the same thing happening in the neck, and these are the sacroiliac joints, which are also initially inflamed, and then there's bone that grows right over those joints. So we want to avoid this situation. Now, it's interesting that in the past, 30, 40 years ago, psoriatic arthritis was thought of as a rare and mild condition. But over the last 2 decades, going on to 3 decades almost, it is now clear that psoriatic arthritis is more serious than previously thought. About 20% of the patients develop clinical deformities and damage resulting in functional disability. And after 10 years of follow-up, 55% of the patients had deformities in 5 or more joints. And we can also see abnormalities on the x-rays. So in 2 studies that were done, 67% of the patients and 57% of the patients presented with an erosion on their first visit to the clinic. There was progression of follow-up over time, and in a new clinic where patients were seen within 5 months of onset of symptoms, 27% already had an erosion, and by 2 years, 47% of the patients had erosions, despite the fact that they were treated with what we call disease-modifying antirheumatic drugs. Now, we know that if a person comes in with 5 or more swollen joints, they're more likely to progress. We know that digits that have dactylitis are more likely to have progression of radiological damage. And we know that the number of actively inflamed joints and the initial sedimentation rate, both markers of inflammation, are predictors of progression of clinical and radiological damage. We now know, thanks to work that Vern Farewell and his colleagues have done in Cambridge, that when you have inflammation in this joint is going to damage. If you have inflammation in this joint is going to damage. So we really want to emphasize that it's the inflammation that needs to be controlled. And through the help of a PhD student with Dr. Richard Cook at the University of Waterloo, we find that progression of damage is linear over time. It just keeps happening, and what we try to do is stop it. The other thing we've learned over the years is that patients with psoriatic arthritis are at an increased risk of death, and that the overall risk is not huge, but it's still recognizable. While the causes of death are the same as the general population, it's related to previously active and severe disease. Now, we also know that over the last couple of decades, this is where we published the information before, and we know that over the last 2 decades, there's been an improved survival in patients with psoriatic arthritis. We'd like to think that we have a role to play by controlling the inflammation through better use of medications and better understanding on the part of the patients. So, what are the goals of treatment? We want to, first of all, identify patients with psoriatic arthritis early. In some of the talks you've heard earlier, basically try to reach that goal. We want to identify genetic markers, environmental factors, and biomarkers that will identify those people with psoriasis that are likely to develop arthritis. And we say that because we know that 85% of patients with psoriatic arthritis develop their arthritis either at the same time or after the development of psoriasis. So for 85% of the patients, we already have a biomarker, the presence of psoriasis. But we know that only 30% of patients with psoriasis go on to develop psoriatic arthritis. So we want to identify those persons early. The next thing we want to do is we want to ease the pain and discomfort. We want to make you feel better. But at the same time, we also want to prevent damage to the joints. We want to maintain function and mobility. We want to improve, and at least not worsen, the psoriasis. We want to improve quality of life, and we want to improve survival. So we know how to make the diagnosis a little bit earlier using these criteria. And we also have developed a screening tool. And many of you have completed that screening tool in the clinic. There are a number of tools that have been developed. The one that we developed, the Topaz, actually can identify psoriatic arthritis either in patients with psoriasis or in patients that go to the doctor for any reason, or even in Kensington Market. So hopefully that will be a good tool for people to use. So what are the therapeutic advances that we have? So in order to understand the importance of the treatment, we have to understand how we measure. So in order to record the ease of pain and discomfort, we have certain measures that we use. One of them is called the ACR, or American College of Rheumatology, 20-50-70 response. That means that the pain, the swelling, the joint tenderness, the swelling, the pain that the patient complains of, the function that the patient has, the way the doctor interprets what the patient does, and the measure of inflammation get better by at least 20% or 50% or 70%, and these are numbers that we can actually show. There's another measure called the psoriatic arthritis response criteria, where it's either the joint tenderness or swelling, the patient and the doctor telling us how bad the patient is doing, and so we can measure those outcomes. We can look at radiologic progression to look at preventing damage to the joints. We can look at the health assessment questionnaire or the medical outcome survey, short form 36, and many of you complete those when you come to the clinic at least once a year. And we want to improve the skin, and you've heard this PsA earlier from Dr. Rosen. It's the Psoriasis Area Severity Index, which again gives us a number that we can record the degree of redness, the degree of thickness, the degree of scale, and the area that's involved with one number that can help us identify what's going on. So when I first started the psoriatic arthritis clinic, we used non-steroidal anti-inflammatory medications, aspirin, naproxen, indomethacin, as the treatment. And when that didn't work, we used gold, chloroquine or plaquenil, Imuran, sulfasalazine, and more recently methotrexate. And some of these medications work in some people. But when you try to apply the measures that I just showed you now, they don't work. And so we've actually been quite frustrated until the year 2000 in our ability to control inflammation and achieve all these goals in patients with psoriatic arthritis. What happened in 2000, the drug etanercept was investigated. It had already been shown to be effective in rheumatoid arthritis, and Dr. Philip Meese in Seattle managed to convince the company, I was not able to do that, but he managed to convince the company to study it in psoriatic arthritis and showed that there was a remarkable improvement. And subsequently, there was a multi-center trial of 205 patients that showed that these are the measures that I showed you earlier. And what you see here, this is the people that got the drug, and this is the people that got the placebo. So it's an injection of something that's water. And you can see that the placebo has very little effect, but the drugs have a very good effect, where anywhere from 50 to 60% of the patients having at least a 20% response, and you can see that about 40% of the patients have a 50% response, and about 70% of the patients in some of the studies have up to 30% response. And this particular, the PsA actually has a remarkable 70% response. Now, these are anti-TNF agents, anti-tumor necrosis factor. Vinod mentioned earlier that we know that TNF is not only a gene that's important, but when you look at the protein that the gene produces, the TNF is high both in the skin and the joints and in the blood in patients with psoriatic arthritis. And so when you use an anti-TNF agent, you actually get a remarkable response. Interestingly, you see that the infliximab and adalimumab and golimumab are anti-TNF antibodies, whereas etanercept is a TNF receptor. So although they do the same thing, the mechanism of action is a little bit different. But you can see that by and large, they have the same kind of response. They all work for the joints. And then there are additional biologic agents that have been developed based on some other mechanisms of the disease. So they're not just anti-TNF. So alefacept is an agent that interferes with cell interactions. You can see that it works in the ACR20, but the response, the higher response is actually quite low. It doesn't work as well. Ustekinumab, which is, again, the anti-1223 that Vinod mentioned earlier, again, works a little bit less than what we saw before, but it has a fair, like a quarter of the patients actually get a 50% response. Now, this is a phase 2 trial, and it's based on the patients getting their medication for 1 month and then assessing them at 3 months. We're now doing a study where people are getting a little bit more, and we'll assess the patients at 24 weeks. Abatacept is also, like alefacept, it interferes with the cell-cell interaction, and again, it has a fairly good ACR20 response. They didn't measure the higher responses. And there is a new drug, which is actually an oral agent, that was just recently investigated, again suggesting that there may be some signal of response here, and there is going to be another trial that's just going to start to try and figure out if this works as well as some of the other drugs. And of course, most people appreciate taking a pill rather than taking a needle. Now, what about the psoriasis? You can see that the anti-TNF agents, which are on the top, work very well for the psoriasis. This is the measure that usually people look at, the 75% improvement in the PsA score, and you can see that the responses are very good. Here, what you see is that the anti-TNF antibodies actually work better than the TNF receptors. So many times when you come to the clinic, we might suggest that if you haven't responded with regards to the psoriasis to the etanercept, we might switch to either infliximab, adalimumab, or golimumab. When you look at the other agents, you can see that the responses are not quite as good except for ustekinumab. So the anti-1223 or Stelara actually has a very good response. And interestingly, this is the effect on psoriasis in patients with psoriatic arthritis. As you heard from Dr. Rosen earlier, patients who present with psoriasis without arthritis actually usually have worse psoriasis And in those patients, the drugs actually show an even better response than we see here, because it's a lot easier to show 75% improvement when you have a higher number than when you have a lower number. But nonetheless, the drugs work. Importantly, and this information we have only for the anti-TNF agent, they all work to improve function, which is measured by the health assessment questionnaire. So the questionnaire ranges from 0 to 3. 1 is considered moderate to severe, and you can see that there is a remarkable reduction, and it actually is sustained for a long period of time. So 1 gets better and stays better. We also see that there's an improvement in X-rays. This looks at a particular way of measuring X-rays, and it shows that in the patients who did not get the real drug, there is further progression of damage, whereas in the patients who got the drug, there is actually a little bit improvement. And when we first saw this information, we said they gotta be joking, because once you have damage, it's not gonna get better. Well, it turns out they were right, because we now have data to show there is actually improvement in damage that was done to a joint, but it takes a long time. It takes 2 to 4 years. But those drugs actually can do it. So again, all 4 anti-TNF agents have been shown to work. We always worry about safety when we have new drugs. These drugs are relatively safe. The main side effects are injection site reactions or infusion reactions. Infections are important, and we're not surprised because we are interfering with the immune system. The same immune system that's necessary to fight off infections. So infections have been a big issue for us, and anybody who's taken an anti-TNF or any biologic agent, if you get an infection, hold the drug. Don't take your biologic agent until your infection has responded to treatment. Because you're fighting the antibiotics if you keep giving the medication that reduces your immune function. You're not letting the body fight off the infection. So you must stop the medication, the anti-TNF agent, or whatever other biologic you might be on, and you resume taking it when you've completed the antibiotics. There are concerns about malignancies. We have not actually seen that in psoriasis or psoriatic arthritis, but we're still concerned. When a drug is called anti-tumor necrosis factor, you gotta worry. Tumor necrosis means that it breaks tumors. And if you are now blocking the factor that breaks tumors, you have to be concerned that there might be allowance for tumors to grow. There is a concern. It has not yet been fully proven, but that's one of the reasons that we need to follow people regularly when they're taking medications. We generally like to see people at 3 months, 3-month intervals. Sometimes we give you 6 months, but we need to see you. You can't disappear for 1 or 2 years because that's the risk we take. And when you come, we examine you. We look for any possible evidence of malignancy that we can pick up, both by clinical examination and by lab tests. So, I've shown you that we can start identifying patients with early disease. We know how to ease the pain and suffering of patients with psoriatic arthritis. We know how to prevent damage. We know how to maintain function and mobility. I didn't show you the data, but all of these drugs have shown to reduce work absenteeism and presenteeism, which means you don't go to work because of your disease, or if you go to work, you don't get your work done. So when you take these drugs, you actually go to work and you get the work done. And we know that they improve not only the joints, but also the skin, so that's a bonus. We don't know about improved survival yet, but we hope that's the case. And we think that's the case because a more recent study that was just published this month suggests that the survival in patients with psoriatic arthritis, at least in England, is better. It's no different from the general population. And that, of course, incorporates only the last 20 years, which is what we've shown as well. So that certainly is very suggestive. So there have been major advances in the therapeutics of psoriasis and psoriatic arthritis in the last decade. New drugs have been life-changing for many patients. The first patient I put on etanercept refuses to come off it because when she got on it, she wasn't able to do anything. With 3 or 4 kids, she was barely able to carry on with some of her activities of daily living. She started the etanercept, and within 3 months, she rented a cottage, she put on a deck, she came back home, she tore a deck, she put on a deck, she painted her house all by herself. And so when I suggest to her, you're in remission, we can get you off the drug, she says, nope, we're not touching this. And we have many patients feel that way, that these drugs have been life-changing for them. However, not everybody responds. You saw that from my table that only 50 to 60% of the patients have an ACR20 response, which means that if you had 24 actively inflamed joints, you may have gone down to 18. But that's still a lot of active disease. Not everybody gets total resolution. So the caution is that while we're very happy with what we have, we certainly are a lot happier this decade than we were in the previous 2 decades, there is still need for newer therapeutic agents, which is why we continue to do our studies, looking for biomarkers, so that we can identify other areas where we can develop therapeutic interventions. So that's all I have to say, and I want to thank you for the attention. And I'm going to call everybody to come back here, the speakers, and we can open for questions. Now, there's a microphone around, so if you raise your hand, Daniel's going to give you the microphone, and then or Arani, but don't both speak at once. So, okay, we'll get the first question.
2 closely related questions. One is there any research about the types of treatment given to psoriasis patients and its effect on later development of arthritis? And 2, I'm reconsidering going back for like a 4th session of phototherapy in the last 5 years. And my observation is that my condition worsens each time I go for treatment. Is that a general observation that the flare-ups get worse over time in phototherapy? And is there any relation between phototherapy and arthritis?
So why don't you start?
So you'll have to help me. What was the first question was?
Any research about that correlates the type of treatment for psoriasis with the later outbreak of arthritis?
Not as far as I know. No, not as far as I know. And then the second questions are about phototherapy.
Well, there may be one issue. Recently there was a drug called ifalizumab.
Oh, yeah.
And there have been some reports of patients treated with ifalizumab. What's the other name for it? Raptiva. So there have been a few reports of patients treated with Raptiva who subsequently developed psoriatic arthritis. What we don't know is whether these people had psoriatic arthritis before and it just unmasked it. And that's the difficulty. But other than that, there is no evidence that any particular drug causes psoriatic arthritis in patients with psoriasis.
What about, I'm sorry, but what about phototherapy, for example, or other types of treatments, salt baths, tar?
In terms of helping or precipitating?
Precipitating?
No data for that at all. In fact, some studies have done about PUVA, for example, where it supposedly worked for both psoriasis and psoriatic arthritis.
Okay, thank you.
Drug name for golimumab.
Golimumab is now called Simponi.
Symphony?
Simponi, S-I-M-P-O-N-I.
It seems that psoriasis is more prevalent now.
Is that just an impression, or it seems I know more and more people that have it, especially in Ontario.
Well, maybe people are just more comfortable talking about it now. Maybe that there's more new treatments available for it. It's more in the public eye. There's more articles being written about it. So, but I don't think that the incidence has gone up.
I think mine has. One other question, is there a tendency that kind of psoriasis can, like I used to get it in the same places all the time.
Right.
And that's changing for me now, and I don't know if there's any kind of, what influences that, or, like I've never had it on my hands, and now I predominantly have it on my hands.
I think one of the things about psoriasis is that it's unpredictable. And you just can't say. It can stay stable for years and then flare. And sometimes we think we know the reason for a flare. We blame it on an infection or strep throat because it's convenient to blame it on that. But sometimes we absolutely have no idea why somebody's flared. So we really don't know. We don't know. And why was it never on your hands before? Why was it never on your ears? And why was it on your knees? I mean, we really don't know. Sure.
I just wondered why it increased morbidity, and if that was just, if it was certain diseases or certain causes of death, or if it was just sort of weakened your system. Like, why is it correlated with that?
I'm not sure that I understood the question.
Weren't you saying was sort of correlated with earlier death?
Why? What is it about psoriasis
No,
that increases morbidity and mortality?
Mortality, sorry.
So I hoped that I emphasized enough the word inflammation.
Okay.
So the idea is that it's the severity. There are studies, what I showed you, studies that we've done here, but there are studies in patients with psoriasis, some of whom have had psoriatic arthritis, because in other centers people don't pay close attention to whether or not they have psoriatic arthritis. But many studies have shown that there's also increased mortality in patients with psoriasis, and it is related to the severity of the psoriasis. So the degree of inflammation is what is the major disconcerting thing, and that's why it's important. And I think partly people may be coming out of the woodwork in terms of having psoriasis now because there is better education that it's not just skin deep. That we're not just talking about skin disease, and it's not just that it doesn't look nice and you shed. It's important because the inflammation has consequences.
So to add a postscript, but the reason why I asked the question is the people that I talk to that have experienced it throughout their lives seem to be inundated with it more often. I know more people who are actually getting more triggers now. That was the point I was trying to refer to. It's not that more people talk about it. For me, it seems that the more people that I know experience more of the negative side effects of it these days, especially in Ontario.
I don't know. There may be some more environmental factors that we need to look at. Okay, who's next?
Hello. I have a question on the genetics. Are there any, I don't know how many people get tested genetically, do a genetic mapping. Is it rare? It sounded like it was expensive.
In our clinic, every single person signs a consent, and we have done the genetic testing that Vinod has spoken about in all of our patients, both in the psoriasis cohort and the psoriatic arthritis cohort.
But it's part of research. It's not done as a clinical test.
Right.
Right. So is there any testing to determine which drugs match the genetic markers or work better with different genetic mapping?
So for drugs, we've looked at some genes that affect the response to methotrexate and identified two genes that may be of importance. But we don't have enough patients to kind of definitely show that. In the near future, we'll also be looking at if anti-TNF, any of the genetic markers, help us identify who's going to respond better to anti-TNF agents. So what we've been doing is collecting the DNA and looking at specific markers. And soon, I've talked about the genome-wide scans. We're looking at the entire genome, not at each nucleotide, but not at each of those 4 letters, but looking at regions where we think it's important, or at regions that basically looking at using 1 million markers all over the genome to see if there is an association. So we are part of a large study that's going to do that, and because, as I said, we need thousands of patients, so one center cannot provide all that. And once you do it once, you need to replicate it in other sites. So that will be done over the next few months, and then we'll have some idea about psoriatic arthritis. And then how technology is going towards is to do a sequencing. So look at your whole DNA, look at all the digits. They've not done that for psoriasis yet because it's very expensive. So in the next few years, as the costs come down, it'll be done. But then when you have that information, the challenge would be to mine the data and do an analysis to actually identify the gene. So I guess in the next 5 years, most of the genes would be discovered, and then you have to do other studies in the lab to identify how an abnormal gene is causing the disease. And then from that would come out new therapies, hopefully.
We actually had a grant submission to Genome Canada, but they didn't think our cause was important enough.
In talking about the effect of inflammation, and I saw in one of the posters in the hall, it talked about insulin response. Is there a strong percentage of people with psoriatic arthritis who go on to get diabetes?
There appears to be an association. We haven't quite gotten the data. Did you get the data? No, this is a study that's ongoing. We haven't quite got the data out to answer this with certainty from our own data, but there's a suggestion from the Utah cohort that there is an increased prevalence of diabetes.
And would that be a factor in the increased mortality rate?
It certainly did not come up as a factor in our studies, but it may be a factor because of the contribution to heart disease and the metabolic syndrome. Again, hopefully next year we'll have an answer to that.
I may have misunderstood you, but if inflammation is this important, did you not say that I would have thought that those with the most pronounced forms of psoriasis would then have been more likely, the higher incidence of getting psoriatic arthritis, but I thought you said the reverse, that it would tended to be a lesser incidence of psoriasis that was correlated.
That's a very good question, and in fact, population studies suggest that it's patients with more severe psoriasis that get psoriatic arthritis. What we have shown you is in our clinic, the patients with psoriatic arthritis don't appear to have as severe psoriasis. And the reason for that is, we think, is because most of the patients with psoriatic arthritis tend to be treated with some form of disease-modifying medication, methotrexate, sulfasalazine, some of these things. Certainly methotrexate works for psoriasis, whereas the patients that are seen in psoriasis clinics, the majority of them do not receive constant systemic medications. They receive courses of phototherapy, as we've heard. They receive topical medications, which they put on and off. And so that could be the reason. But the notion out there is that patients with more severe psoriasis are the ones that are likely to develop psoriatic arthritis. We still have to prove that. So far, those 10 patients that have developed psoriatic arthritis within the psoriasis cohort that we have here have not shown that. But it's too early to tell.
Yes, this kind of veers a little bit off topic, but I understand there's some correlation and interrelation between other autoimmune inflammatory conditions, especially IBD. When it comes to knowledge transfer and cross-pollination, are there anything between your research and other research around the world with other autoimmune conditions which seem to be treated very similarly? Is there any cross-pollination in terms of studies and research and therapies?
So we know that there's a group of diseases that go together: psoriasis, psoriatic arthritis, ankylosing spondylitis, eye inflammation or uveitis, and inflammatory bowel disease. In families, you can see one sibling having Crohn's, the other person having psoriasis. So it tends to go together. And even with, if you look at people with IBD, they tend to have more psoriasis than the general population. So there are some common genetic elements, and Currently, as we speak, there's something called an immunochip. Immunochip is a chip for DNA testing, where all the genes important in immune diseases are on that chip. So if you test patients and controls to see if the immune genes are they associated with the disease. So genotyping on the immunochip has just been done, and we'll soon know what are the immune markers, genes that are important in immunity, how they affect psoriasis and psoriatic arthritis. And with that data, we'll be able to compare with Crohn's disease, ankylosing spondylitis, and other autoimmune disease like rheumatoid and thyroid disease to see what the relationship is. Because there is a susceptibility to autoimmunity, and then some people get psoriasis, some people get lupus. So by this study, we'll get to understand that better.
So the answer is there's lots of cross-pollination. We ourselves are part of a group called SPARC, which is Spondyloarthritis Research Consortium Canada, which includes psoriatic arthritis, ankylosing spondylitis, reactive arthritis, inflammatory bowel disease arthritis. We work very closely with our the gastrointestinal specialist. And on the international level, we are participating in this immunochip in two ways. One is through SPARC, through the ankylosing spondylitis group, and the other one is through IPART, the International Psoriasis and Arthritis Research Team, which we actually direct from here. And we're participating in immunochip there. This is already on the way. And there is a meeting actually that's going to take place in Shanghai, China, where the first results of the immunochip are going to be presented. So there's lots of cross-pollination. By the way, some of the genes that Vinod has spoken about, we already know that they are markers for more than one disease. So for example, Crohn's disease has an increased frequency of IL-23. And it turns out that now they're testing Stelara in Crohn's disease. The TNF is also a factor in inflammatory bowel disease, as well as in eye disease. So now we're looking at more than just those diseases. We're looking at diabetes genes, we're looking at lupus genes, we're looking at multiple sclerosis genes. So all of these immune-mediated diseases are, the genes that have been reported in these autoimmune diseases are all on this immunochip and are now going to be tested across a number of diseases that are immune-mediated.
On a practical level, some of these drugs were approved first for people with Crohn's disease. So I would have a patient who had Crohn's and psoriasis, and I would see their psoriasis is doing great on this new drug for Crohn's. So I'm sure that there was cross-pollination and applying a drug that worked for one disease to another, because people who had both were getting better. So there was definitely in the therapeutic side that kind of work going on.
Well, over the years, I've participated in several surveys. Hello?
Yes.
Oh. Over the years, I've participated in several studies, and I just was curious about who are the patients that are participating in all the very hard to say and long named drugs that you're speaking of. Are these drug company surveys, or are they your surveys? Who's buying the drugs? And if the people are buying them themselves, wouldn't this eliminate a big financial part of the population?
That's a very good point that I didn't mention earlier. One of the deficiencies of the drugs is they're very expensive. So the initial studies usually are carried out by drug companies, and they're usually multi-center because you need hundreds of patients. And we've been fortunate enough to participate in some of these studies, and our patients obviously benefited. Some of these studies, you start the study and they continue the medication for you for, in one case, at least 5 years. So it's actually quite beneficial. Some of the studies we've carried out ourselves here, or we've led a Canadian consortium of investigators. Most of the time, when a person participates in a study like that, the drug is given by the company Sometimes the study is based on only those patients that can get the drug either from their insurance company or from government support. So if you're 65 or over and the drug is approved, then you can get the drug free of charge. If you have an insurance policy that allows you to get the drug, you can get the drug. And if you have an insurance company that doesn't cover all of the drug, say they cover 80% or 70%, then you can get Trillium to pay for the rest of it. And so a lot of people do get these drugs, quote, free. We're obviously very sensitive to the fact that these drugs are very expensive and that they're not available to everybody because of the cost. And we're trying to talk to our industry partners to see if they can reduce the price. And many of the pharmaceutical companies are actually very helpful in allowing us to at least give trials to our patients to see if they actually improve, and then we can figure out ways to get the drug for a patient.
Well, are these drugs not approved yet?
Those drugs that I showed you are approved, yeah.
Well, isn't the lifestyle of individuals a big factor in their health in general, and that a poorer portion of the population usually has poorer health issues?
But you see, if you're poor, you're covered by the Ontario drug benefit.
No, you're not. No, you're not. That's fallacy. There's a lot of drugs that are not covered.
Well,
those are
those drugs actually are available through the Ontario Drug Benefit Program to people who qualify for
Trillium?
Trillium, for sure.
Trillium is costly.
No, but this is ODB pays for these drugs.
All the ones that were listed there?
Yeah.
Well,
they pay for
the
a certain
anti-TNF
number of them.
agents are all approved. The other drugs, Stelara is approved for psoriasis, not for psoriatic arthritis. Alefacept is approved for psoriasis. And what else did we have there? Apremilast is still being tested. And what was the other? Abatacept is still being tested.
Well, all right, I go along with that because you obviously know, but I just have never been part of any one of those studies, or I can't.
Okay, so let me tell you
I
what
can't say that I've been asked to try some of those drugs.
In order
any ones that
to
I have been, I couldn't
get the
afford.
drug, whether in a drug trial or whether from either an insurance company or the drug or Ontario Drug Benefit Program, you actually have to qualify for drug. And you qualify for drug for psoriasis if you have 10% body surface area or a PsA of 8 or 10. And you have to have scored 10 on the Dermatology Life Quality Index, which is the quality of life measure.
You also have to fail phototherapy and fail methotrexate.
Yeah, and you have to fail the two modes of therapy. In psoriatic arthritis, you have to have failed methotrexate and leflunomide, and you have to have 5 swollen joints before you can get one of those drugs. So if you're not asked to participate, it's probably because you don't qualify to get the drug. Most of the drug trials require 3 to 5 swollen joints and at least a target lesion of psoriasis for the therapeutic trials. So it's not, the drugs are not used for people that have very mild disease. There has to be a significant degree of disease and a failure of the common therapies. Now, what we're trying to do is we're trying to get the drugs earlier for people, and we're hoping that some of this information that we're looking at in terms of environment, in terms of genes, that will identify those people that should get the drug even if they haven't failed anything, because those are the people that are going to damage very quickly. We want to get the drugs to them right away and turn off the process of the disease. That's what we need to do. We still need more research to be done to convince the governments and the payers that this is the right way to go. There's some questions down here. Are you, Gordon had a question. He's had his hand up for a while.
You talked about the Northern European countries that used them. I'm it was mentioned that in, I think, the Scandinavian countries and Newfoundland, higher incidence of psoriasis. Do we think that there's a vitamin D relationship?
Okay, that's a good question. Because vitamin D was suggested to be a protective factor for autoimmune disease in several studies. And we have tested recently whether vitamin D levels are related to disease activity. And we found no association between the levels of vitamin D and the levels of disease activity. We actually did the studies in 2 sites. One was here in Canada and the other one was in Israel, where we expected to see high levels of vitamin D, and in both sites there was no association between vitamin D and disease activity.
Is there a length of treatment time before you can determine a failure rate for the lenalidomide and the methotrexate if they're being treated together before you would go?
3 months. One has to be on the drugs 3 months.
What I was wondering is the mortality rate, is it also increased by the drug treatment?
That's a very good question. In our studies, the drugs didn't come in as predictors, and the mortality studies that we did were pre-biologics.
So I don't know what that means.
The antitinef, the new drugs that I showed you now, had not been available at the time that our data was collected. Whether some of the other drugs might have contributed, it's possible, but as I say, in the analysis, the drugs didn't actually come in as predictors.
Two questions. Firstly, if we have children, if we have psoriatic arthritis and we have children, is there anything we should do from a preventive point of view as they grow old and get through adolescence and into their 20s?
So, when you look at the risk of near relatives developing the disease, it's higher than somebody else who does not have psoriasis. So, the genetic common familial risk factor is there. So you got, and once it's there, we don't know exactly what are the genes are. So hopefully over the next decade or 5 years or so, we'll be more, we'll know more about genes and maybe test whether if the risk genes are present or not. Once we know that, it's a difficult and ethically problematic question. Do you really want to know, if you have the genes or not? And there are a lot of issues with that. But if you think that we do want to know, then what can you do about it? Like I said, genes are important, and there's also an environmental factor. And what are the environmental factors that are important for both psoriasis and psoriatic arthritis? One is obesity. Smoking increases the risk of psoriasis, although the arthritis is, and then trauma. People tend to have injuries, tend to get more of not just osteoarthritis, but more psoriatic arthritis after injuries. So, looking from a practical point of view, it will be important to stay fit, and exercise is important. Try to avoid injuries and not smoke. So, all things that you do to live healthy is important in preventing the disease from happening. Somebody was talking about, is the disease more prevalent now than before? There's one study from Rochester, Minnesota, where they looked at the administrative database to see if the incidence of psoriasis is increasing or not. And in that particular region of Minnesota, according to patients' report and the doctor's identification of psoriasis, over the last 2 or 3 decades, the prevalence of psoriasis and the incidence of psoriasis has gone up. So the question then is, why is psoriasis increasing, if that is true? And we all know there's an obesity epidemic, and we also have studies to show that obesity predates the development of psoriasis. So maybe being obese is is an important risk factor, and we need to work towards that to decrease the obesity epidemic in the future generations.
Second quick question, more speculative. Do you get a sense as a team that you're getting closer to it quicker than in prior decades? Like, I think this biologic drugs and the things that are out more recently have given us a lot of enthusiasm towards it, as I've heard you say, and I can experience it. Like, my life is given back to me. Do you see in another decade or two that this thing could be potentially solved?
I've been in this, I've been studying psoriatic arthritis for many years now. In the first 20 years of doing it, I was one of 5 people in the world that were actually looking at the disease. In the last decade, there's been a significant interest in psoriatic arthritis, to a point when in 2003, we actually established an international group called GRAPPA, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. And there are now close to 350 members of that group, and we meet several times a year, but once a year we have a meeting that's dedicated only to specific issues for psoriasis and psoriatic arthritis. Importantly, this is a group that includes rheumatologists, dermatologists, radiologists, other physicians and methodologists, and it includes also members of the pharmaceutical industry and members of government agencies that actually support drug development, as well as patient groups. So in the last 10 years, there's been a significant interest and a proliferation of studies. We have a number of international, I told you about IPART, we have a number of international efforts to try and get to the biomarker story. The GWAS that we're currently doing includes 12 centers around the world. And my feeling is that over the next 5 to 10 years, we're actually going to identify the genes, and we're also going to identify some biomarkers that are going to be very relevant for both identifying patients' destined to get the disease, patients destined to develop good or bad disease, and we'll probably be on the way to developing some newer therapies. Now, it may very well be that some people will need to be treated with more than one agent because they have 2 or 3 different immunologic abnormalities. And so, whereas in one person it's mainly the TNF that's the issue, in another person it may be the TNF and the IL-23, in another patient it may be IL-4 that's the issue, and we don't know how to deal with that yet, and so on and so forth. So I actually do believe that over the next decade, we will have really significant improvement in understanding and treating patients with psoriasis and psoriatic arthritis. I'm very optimistic. The fact that there are so many people now involved in the study, there's more money going into the field in terms of investigation, Genome Canada notwithstanding. You know, we are on the verge, and that's why it's so exciting to have the team and to have the team grow, and having the team both clinicians and technicians and statisticians and assistants that help us do all this work so that we can do it better and faster. I think we should probably call it a day.